So, what is new in vascular access in terms of data coming out currently? I think the hottest topics is, of course, the percutaneous creation of arteriovenous fistula. And on the other hand, of course, we have lots of data coming out, especially for drug-coated balloons, as a randomized trial recently coming out for the Impact AV balloon from Medtronic. And of course, we also have some interesting data coming out for covered stents. As far as it concerns the percutaneous creation of arteriovenous fistula, we have two systems that are currently approved for use in the United States and in Europe. In terms of reimbursement, both systems are currently reimbursed and being used extensively in the United States. Reimbursement is not as far advanced in Europe. Therefore, utilization in Europe is less extensive. The two systems, of course, is the ellipsis vascular access system that I have been particularly involved, which is using the tissue fusion, essentially thermal energy and pressure, to create anastomosis between the proximal radial artery and deep communicating vein. And of course, the wavelength system that has been acquired by BD and is using radio frequency current to create a communication between either the radial artery, the adjacent vein, or the ulnar artery and the adjacent vein, and in the previous version of the system, between the brachial artery and the brachial vein. Both systems need a perforating vein at the level of the elbow to transfer the blood to the superficial venous system, and therefore being able to offer dialysis for the patients. Both systems might need some secondary interventions, especially for the ellipsis system that we have studied extensively. We saw that we need to do more dilatations initially in order to achieve dialysis for the patients. However, after the initial period, the patency rates are equivalent, if not superior, to surgical fistula. And of course, this is as compared to results of very experienced centers. What is very good with the percutaneous systems is that this technology is opening the possibility for fistula creation to not only surgeons, but interventional radiologists and nephrologists. Therefore, especially in remote regions or countries like the United States, that you have lots of interventional nephrologist patients, may have more options, may have a fistula creation faster. And also, thanks to the simplicity of the technology, I think that the results may be equivalent to surgical fistula for a larger number of practitioners, meaning that you don't need to have this rare, excellent surgeon that can create a perfect surgical fistula, but you can have a wider diffusion of the technology and good results for many people. As far as it concerns other technologies, the drug-coated balloons and covered stents, it is another advance that we have for vascular access. What we see is that, of course, the results of plain old balloon angioplasty, or more commonly POBA, as we mention it, are not as good, meaning that, of course, it's a first intention, and usually stenotic lesions of the AV access circuit is treated with a simple balloon angioplasty. Sometimes we have to use cutting balloons or high pressure balloons to break the lesion. However, what is very common is to have a recurrence of these lesions, with patients getting balloon angioplasty over and over again, very often having thrombosis or even losing the fistula because of these repeated occlusions. Therefore, the technology was needed, and it seems to be here in terms of reducing this recurrence. So we have drug-coated balloons that are aiming essentially to stop this neointimal hyperplasia. We had some studies, mixed results essentially for the last few years, but most recently we have the data from the IMPACT AV access trial with 3 years results that shows unequivocally that we have improvement of the target lesion primary patency and the patency of the entire circuit when we're using drug-coated balloons, which of course can be translated to improved patency for the fistula, improved quality of life for the patient, and less risk for losing the fistula. The other way to treat these lesions, of course, are the covered stents instead of a drug-coated balloon, which basically aims to kill the cells essentially and avoid having linear-intimal hyperplasia. We have covered stents that cover these lesions, and we also have some new stents coming out. Very interesting data demonstrating probably superiority from drug-coated from POBA. It remains to be seen whether DCBs or covered stents are better. And of course, it would be a great opportunity if you join us in Paris, and you will be able to find for yourself with all the experts we're having. They're going to talk about percutaneous creation of fistula. They're going to talk about DCBs, covered stents, and everything else. And you will be able to find for yourself which one is the best. Thank you very much for watching this video, and I hope to see you in Paris.